Good evening, everyone. How are you all? All right. So let's start our tonight's session. Yeah, that's right, Dr. Sophia. It is quite cold in Australia now. So let's finish our obstetrics tonight. Okay. So we finished up to the high risk pregnancy in our last session. So tonight we are going to start with early pregnancy bleeding. So do you guys have any questions from our previous class on obstetrics, or you're all good? Or you haven't got enough time to even start it? Yes, Dr. Mehra, what's the question about preeclampsia? And Dr. Chandima, it's not needed. So the referral process will not be important for MCQ exam. Okay, so no need at all to discuss that. Yes, so to diagnose preeclampsia, proteinuria is must. That's must to diagnose it. Yes, definitely. Okay, moving on to our tonight's session with early pregnancy bleeding. Early pregnancy bleeding means that if bleeding happens in a pregnant patient who is less than 12 weeks gestation. So we divide pregnancy into 3 trimesters, first, second, and third. First trimester is basically up to 12 weeks, and then up to 28 weeks is second trimester, and after 28 to 37 or up to delivery is third trimester. So first trimester bleeding is early pregnancy bleeding. So what is the most common cause of pregnancy loss or miscarriages in first trimester? So this question comes in exam a lot. So if the question say that what is the most common cause of recurrent miscarriages in the first trimester? The main cause of recurrent pregnancy loss is chromosomal abnormality. Okay, so chromosomal abnormality will be the most important or most common cause. Antiphospholipid antibody syndrome is an uncommon cause of early pregnancy loss. Okay, it's not very common. Like I haven't seen even like maybe like not even a few patient who has got antiphospholipid syndrome. So it is not a common diagnosis that we get in a patient. But the common cause of early pregnancy loss should be chromosomal abnormality of the baby. So what are the causes? If we think of early pregnancy loss, we are mainly talking about miscarriages. Or if we are talking about early pregnancy bleeding, miscarriage is one of the most common causes. Apart from miscarriage, other than it could be like ectopic pregnancy, molar pregnancy, those are also causes of early pregnancy bleeding. So what are the miscarriages that comes in exam? The important one for your exam is threatened miscarriage, incomplete and complete miscarriage. Inevitable doesn't come in exam, and you can remember about missed abortion, that's fine, but mainly threatened, incomplete, and complete comes in exam. So how to differentiate between all of these miscarriages? So threatened miscarriage means that patient coming to you with a mild parvaginal bleeding, and maybe like very unlikely they will have abdominal pain, but they can have like a mild abdominal pain. So everything is mild PV bleeding, mild abdominal pain. And then when you examine the patient, you found that their cervical os is closed. So if you have got a patient who has mild PV bleeding, mild abdominal pain, cervical os is closed, and then you do an ultrasound, and ultrasound confirms that yes, the baby is in the uterus, not ectopic, then you can say it is threatened miscarriage. So how we are going to like manage this patient? So if let's say a 10 weeks patient coming to you with a mild parvaginal bleeding for the first time in the pregnancy, cervical os is closed, what will be your next thing? The next thing is that you need to make sure that first pregnancy is like intrauterine, and then if it is intrauterine, is the pregnancy viable? So you need to go for an ultrasound to confirm that. So first you do an ultrasound, make sure the baby is alive. And then if it is, then you can reassure the parent, or you can reassure the mother that there is nothing else needed to be done. This kind of patient needs to be on a strict bed rest, no excessive exercise or exertion. And most of the patient who gets threatened miscarriage, they will end up having a normal, healthy baby eventually. So you can reassure them about it. Okay? So that's threatened miscarriage. What is incomplete miscarriage? Incomplete miscarriage, patient will come to you with a severe parvaginal bleeding with severe abdominal pain. And they will also say that they might have noticed that some part of the fetal tissue has already been passed. So that's the main finding: severe bleeding, severe abdominal pain, and some part of the fetal part has got already removed. And if you examine them, the cervical os will be open. Okay, so what would you need to do for this patient? This kind of patient, because of heavy bleeding, they can get into a shock. So if shock develops in this patient, then first thing you need to notice that if there is any product of conception or any fetal tissue still staying at the os. So sometimes what can happen, that part of the fetal tissue can stay at the cervical os. And when it happens like that, os will be open and patient can get cervical shock. So even if you give lots of like fluids, blood, the bleeding will not stop. Or the main thing is that the shock will not improve. So what you need to do is to remove that fetal tissue with the consent of the mother. And once you remove the fetal tissue, the shock or the blood pressure will improve. So first of all, you need to find out if there is any fetal tissue at the cervical os. If it is there, you need to remove it. If there is none on the cervical os, then what do? You can do an ultrasound, confirm if there is anything left, and then if it is, then you can go for a DNC. So this patient will need an emergency DNC if bleeding is heavy. So emergency suction DNC if bleeding is heavy to prevent further blood loss. Otherwise, conservative management awaiting spontaneous complete abortion or induced contraction with misoprostol. So that can be done. So if it is a heavy bleeding patient getting into shock, then definitely you need to go for DNC. If patient is not in shock, not heavy bleeding, then you can wait for the fetal tissue to pass away by itself, or even you can induce contraction by misoprostol. So that's incomplete miscarriage. Okay, so os will be open in this case. What is complete miscarriage? Complete miscarriage means that the whole fetal tissue has been already removed, or the patient already found that there is complete passage of fetal part. So initially patient will have abdominal pain and bleeding, and after that there will be complete passage of the fetal tissue, and then the bleeding and abdominal pain will be settled. If you do an examination, you will find that cervical os is closed, and you need to do an ultrasound to confirm that there is nothing left inside the uterus. Okay, so that's complete. What is missed miscarriage? Missed miscarriage is that patient did not have any symptoms, no bleeding, no abdominal pain, and for some reason you have done an ultrasound, you have found that it's a non-viable pregnancy. So it's an ultrasound finding of a non-viable pregnancy without any symptom. So in that case, definitely two things can be done. You can do an elective suction D&C, or you can do a conservative management, awaiting complete abortion, or you can even induce contraction with misoprostol. Okay, so that's basically that main one that comes in exam: missed miscarriage, threatened, incomplete, and complete. Septic miscarriage, very rare in Australia, doesn't come. Inevitable doesn't come. No requirement of hormone therapy in threatened miscarriage. Thickness of the endometrium, that will be given by the ultrasound. Okay, so ultrasound will comment on that. And difference between chronic hypertension and pregnancy aggravated hypertension. There is not much of a difference. Chronic hypertension patient means that patient previously, before getting pregnant, patient has hypertension. And pregnancy aggravated means that patient had hypertension. Now, when they became pregnant, the hypertension has got a lot worse. That's pregnancy aggravated hypertension. But both of these cases, patient already had hypertension even before getting pregnant. All good, everyone, with the miscarriages? Any question? Okay, today also I think there is an issue with the capacity. Okay, let me just stop sharing. I will just increase the capacity of the Zoom meeting. You can see that still few people can't join the class. Just give me a moment, guys. Perfect. Okay, let's continue. Yes, so it's the same thing, Dr. Aspa. Most common cause of early pregnancy loss or most common cause of recurrent miscarriage in early pregnancy is chromosomal abnormality. APS is not the most common cause of anything. Okay, so if the question asks what is the most common cause of recurrent miscarriage in early pregnancy, that will be chromosomal abnormality. Most common cause of recurrent miscarriage in second trimester, that's cervical incompetence. So APS is not the answer of anything. Ectopic pregnancy. So very, very important topic for your exam. We did discuss ectopic pregnancy in gynae. Do you guys remember that? So how much beta HCG has to be to confirm that it is ectopic pregnancy by an ultrasound? 2000. Very good. Yes. So if you can answer that, then you are good. Okay. So moving on to molar pregnancy. So what is molar pregnancy? Molar pregnancy is also another cause of early pregnancy bleeding. So in this case, the normal embryo will be replaced by some gestational trophoblastic tissue. That's all that you really need to know about it. So molar pregnancy means that when the normal embryo, which should happen between a sperm and ovum, will be replaced by some gestational trophoblastic tissue. And gestational trophoblastic tissue is definitely, it's not a viable pregnancy or viable fetus. So, but the pregnancy test can come positive in this case. Patient can have all the early pregnancy symptoms as well. You can see here, there is a risk that sometimes persistent molar pregnancy or hydatiform mole can become invasive and penetrate the uterus and even can metastasize to the lung. 1 in 20 can develop into a choriocarcinoma. So that's our main concern with molar pregnancy. So in molar pregnancy, what happens that you might be able to treat the patient fully, but they need a frequent follow-up because some of these patients can turn into a choriocarcinoma later on. And this cancer can metastasize into the lungs. So how molar pregnancy presents? So first of all, patient will have bleeding in early pregnancy, and they will complain that they have seen some grape-like structure coming out of their vaginal area. So parvaginal bleeding in early pregnancy with grape-like structure coming out or bubble-like structure coming out, that's molar pregnancy. This patient also get exaggerated symptom of pregnancy, which is what we call as hyperemesis gravidarum. So patient will have more nausea and vomiting in comparison to a normal pregnant patient. And also the uterus will be large for dead in this patient. Okay, so that's the main finding. Bleeding, grape-like structure, excess nausea, vomiting, and uterus larger than the gestational age. So if you suspect molar pregnancy, what would you do next? Definitely, first of all, you need to confirm pregnancy. So you do a urine pregnancy test. Then you send the patient for a beta HCG. You will find out that beta HCG is very high in this patient. So in comparison to the normal beta HCG, this patient's beta HCG will be super high. So that will lead you to think that yes, this could be a molar pregnancy. Then if you need to confirm it, you do an ultrasound pelvis. And ultrasound pelvis gives you a typical snowstorm appearance. And that's the main thing that can confirm molar pregnancy. So once it is confirmed, what would you do next? You need to remove this like abnormal trophoblastic tissue. So the main treatment is suction curettage. So you remove it by suction curette, and also you can put the patient with oxytocin drip to reduce the bleeding and to induce contraction. So once you remove it by suction curette, your job is not done there. There is a follow-up that's very important. It comes in exam. So for this patient who you have diagnosed as molar pregnancy, patient will need to have beta HCG every week until it becomes 0, which can take 8 to 12 weeks. After that, every month for the next 12 months, you'll have to do a beta HCG. So every week until beta HCG becomes 0, and then every month for at least 12 months. In this 12 months time, you will advise the patient not to get pregnant, because if they get pregnant, beta ECG will be elevated, and it will confuse us that whether it is like cancer or whether it is pregnancy causing the high HCG. So that's why we advise them not to get pregnant in the next 12 months. So you can put them on contraceptive pill in this time period. Now we say that if beta HCG does not become normal after 3 months, or after 3 months it got better or 0, but after 0 suddenly it again got elevated, then you need to send the patient to a specialist for a cytotoxic therapy, which is methotrexate and folic acid. And in this situation also you need to make sure there is no metastasis in the lung, so you need to do a chest X-ray. Okay, so that's the follow-up for molar pregnancy, comes in exam. So that's pretty much everything that you need to know from early pregnancy bleeding. Any question? No, Dr. Fatima, it's not same in here. We don't start exam for everyone. Moving on to the next topic, infection during pregnancy. Very important, and it's not available in John Murtagh 7th or 8th edition. It's only available in 6th edition. So I'm opening the 6th edition, chapter 109. So start this one. Infection during pregnancy, super important for exam. So let's start. First of all, urinary tract infection. So all of you know how the urinary tract infection usually presents. So acute cystitis means that infection of the lower urinary tract or bladder. Lower urinary tract mainly comes with dysuria and frequency. So patient will have burning discomfort, they will have increased frequency of urination, and that will make you think that, well, it could be cystitis. So you do a urine dipstick, it will confirm that yes, there is leukocyte, and then you will start the treatment with antibiotic. So the choice of antibiotic is either you can use cefalexin or amoxicillin clavulanic acid, nitrofurantoin, but you can't use nitrofurantoin in the 3rd trimester because it can cause hemolytic disease in the newborn. So basically cefalexin or amoxiclav is the treatment of choice. Okay, so for acute cystitis, the treatment period is 10 to 14 days. Now again, in John Murtagh, if you go through pregnancy acute cystitis, they still put it as 5 days. So I would advise that the new edition, if you go to the UTI chapter in John Murtagh in 8th edition, that we will follow the duration, whatever it's written in new edition. Okay, so acute cystitis, mainly they ask you about the antibiotic name. Duration doesn't come in exam, but you need to know which antibiotic you can use. In a non-pregnant patient, your first line antibiotic is trimethoprim. So we either use trimethoprim or we use cefalexin. But trimethoprim cannot be used in a pregnant patient. So for pregnant patient, cefalexin is the choice, or amoxicillin clavulanic acid, or nitrofurantoin. Okay. How about pyelonephritis? Pyelonephritis means infection of the kidney itself. So patient will not have that much of a dysuria or frequency. Rather, they will mainly have systemic symptoms. So fever, nausea, vomiting, chills, and flank pain. So when you have got a patient with maybe a bit of dysuria frequency, but more systemic symptom, you would think of pyelonephritis. So for pyelonephritis, patient needs to be sent to the hospital for IV antibiotic, and the antibiotic of choice is IV amoxicillin. If amoxicillin is not possible, like to penicillin, then you can try IV ceftriaxone, and once patient is bit stable, you can switch it to oral cefalexin. Okay, so there's the treatment for acute pyelonephritis. There is a condition called asymptomatic bacteriuria. Asymptomatic bacteriuria means that patient doesn't have any symptoms. But when you have done a urine microscopy and culture, in the urine microscopy culture, you have found patient has got an organism. So that's asymptomatic bacteriuria. That means in the urine there is a bug, but patient doesn't have any symptom. So 5 to 10% of pregnant patients will have this kind of asymptomatic bacteriuria. Among them, 5% subsequently can develop pyelonephritis. That's why this is the only time we are going to treat an asymptomatic patient. So only time you treat asymptomatic bacteria is when patient is pregnant. So treatment is recommended according to the culture sensitivity. It is preferable to delay it until the first trimester has passed. In any other patient, if they are asymptomatic, we don't treat even if there is a bacteria in their urine. Okay, but for pregnant patient, you will need to treat them. No, we don't use trimethoprim in pregnancy. Next. So you have got cystitis, pyelonephritis, and asymptomatic bacteriuria. Next is puerperal infection. So following childbirth, if a patient has got infection of the genital tract, that's what we call as puerperal infection. The commonest cause of puerperal infection is GBS, which is group B streptococcus. Now, this GBS is carried by 15 to 20% of pregnant women. Okay, so 15 to 20% of pregnant women will have GBS when they are pregnant, and they would not have any symptom. But the problem is that because of this GBS, when they deliver the baby, that time this GBS can cause lots of infection in the pregnant patient and also in the baby, because it can pass into the baby during the childbirth. And this GBS can cause pneumonia in a child. So that's why every pregnant patient will have a routine test for GBS at 36 weeks. Okay? So every pregnant patient will have GBS at 36 weeks. So it's kind of like a swab from the vagina to check for GBS. So if antibiotics are not given to carriers in labor, so if you don't give antibiotic in a GBS carrier, 50% of baby will become colonized with this bug, and 1% of these are severely affected and can often die. And if you give antibiotics during labor in a GBS carrier patient, fetal colonization and infection almost never occurs. That's why we say that if a pregnant patient at 36 weeks, when you do the GBS, if the patient is GBS positive, then what would you do? You would give them benzyl penicillin IV, first 1.2 gram and followed by 600 milligram every 4 hourly until delivery. You don't need to know the dose. Just remember IV benzyl penicillin has to be given every 4 hourly until delivery in a GBS carrier pregnant patient. If patient is allergic to penicillin, then treatment of choice is clindamycin. So that's how we manage the intrapartum GBS prophylaxis, or that's how we manage the GBS during pregnancy. The high risk situation is that if a patient has got premature rupture of membrane, then it's very common that this GBS can cause chorioamnionitis, it can cause lots of infection. Okay? Intrauterine sepsis. So let's say you haven't found GBS, or you haven't tested the patient for GBS during pregnancy, and somehow during the birth time, this GBS has now infected the uterus of the mother. And it's not unusual because during birth, there will be placental delivery. The uterus will be raw, okay? And you can easily get infected if there is already a bug there. So maternal puerperal GBS infection is usually what we call as endometritis. And its presence as high fever, chills and rigors, tachycardia, okay, nausea, vomiting. They get this offensive purulent vaginal discharge and also sometimes abdominal pain. So if you get a pregnant patient following delivery having PV bleeding, vaginal discharge which is foul smelling, abdominal pain and fever, you would think of puerperal sepsis or endometritis. So your next thing would be to take a swab from the genital tract, and then depending on if the patient is not looking very unwell, then you can treat them as outpatient amoxiclav. If patient looks septic, then you need to send them to a hospital for IV amoxicillin, gentamicin, and metronidazole. Okay? Any question, guys? So let's see. 6th edition. Okay, I can give you the PDF of 6th edition. And trimethoprim used in pregnancy? No. No, not Dr. Aisha. We don't use trimethoprim in 3rd trimester. Do we do a culture test in 1st trimester routinely? No. We don't do the culture or we don't do the vaginal swab in 1st trimester. There is no need to go for C-section because patient is GBS carrier. Okay, patient can go for normal vaginal delivery, but all you need to do is during labor, you need to put the patient with IV antibiotic. This is not an indication to go for C-section. No need. So if cesarean section is done, we don't need to give the prophylaxis. How to find out a GBS carrier? As I say that every pregnant patient will be routinely tested for GBS at 36 weeks. So it's just a vaginal swab test. So if you take a swab from the vagina and send it to the lab, if the patient is GBS carrier, they will say that. Okay. So that's all about your intrapartum GBS prophylaxis and everything. Now moving on to some of the viral infection which can transmit from placenta to the baby. One of the most important one is rubella. So we are always concerned about a rubella contact in a pregnant mother. How so? That we say that if a pregnant patient comes in contact with someone who is diagnosed with rubella, and patient or the pregnant mother also end up getting a rubella, especially in the 1st trimester, then there is a 80% chance that it will go to the baby and baby will turn up into a congenital rubella syndrome baby. The problem with congenital rubella syndrome is that there is a lot of abnormality in the baby. So baby can have heart defect, most importantly PDA, which is patent ductus arteriosus. They can have deafness, they can have cataract, and lots of other like organ problems, then intellectual disability. So it's not a good thing to happen. So that's why it is very important to know for the exam. So let's say we have got a patient who is pregnant comes to you because she was contacted recently by a rubella positive patient. What would you do next? Your next thing is to check if the patient is immune to this rubella already, because everyone in Australia, they get MMR, which is measles, mumps, and rubella vaccine when they are a child. So first thing that you need to find out that if they have the antibody or not. So you take the blood and send them for rubella serology, IgG and IgM. All of you know that IgG will be positive if there is antibody or past infection, and IgM positive means recent infection. So you take the blood and you found that patient is IgG negative. Okay. Now in here they say that take blood for IgG antibodies, no concern if negative. Now it's not actually that they did not actually mean that. The meaning is if IgG positive, it means that patient had antibody against it. So let me write it in here so that it becomes a little bit easier for you because it's a bit complicated. So let's say that we have done a test where we found out that patient having IgM positive but IgG negative. IgG negative means patient doesn't have any antibody. And IgM positive means recent infection. So this means patient has a recent infection with rubella. What if IgM negative and IgG positive? That means no recent infection, patient is already immune. What if both is negative, IgM negative and IgG negative? Now this is the time patient is not immune. So you need to do a repeat test in 2 weeks' time. And after 2 weeks, if you see that either IgM got positive or IgG, let's say initial titer was 1/80. And now there is a 4-fold rise of titer. So 1/320. So definitely this is like 4-fold rise of antibody titer. So if 4-fold rise of IgG titer or if IgM got positive, after the 2 weeks time, that will also be confirmatory that patient has got a recent rubella infection. Again, if both is negative initially, you need to do a repeat test in 2 weeks. And if you find that the IgG titer has got 4-fold increased, it's also recent infection. Okay? So in here you can see that if pregnant patient get rubella infection and they're less than 8 weeks gestational age, up to 85% fetus will be infected. Less than 12 weeks, 50 to 80% will be infected. After 19 weeks, there is no risk. So if a pregnant patient got infected with rubella after 19 weeks, then there is nothing wrong. You can just reassure them that there is a very less likely chance of any congenital rubella syndrome. So once you diagnose, what will you do? If the pregnant patient is diagnosed with rubella infection in the first trimester, there are 2 options that you are going to give to the mother. One is that if they want to continue the pregnancy, even after knowing that this is what can happen, you will be with the mother and you will continue with the pregnancy. You will arrange frequent follow-up with ultrasound. Second option, if mother wants to terminate, you will also agree to that. The option will be either continue the pregnancy or termination, but it's up to the patient. You will give options of both. Okay? But never ever encourage the mother that, yes, you should go for termination. It's not your choice, it's a mother choice. Okay. Now, how to prevent all of this? The prevention is that if the patient was vaccinated against rubella, then nothing was actually abnormal. Then it would be totally fine. The problem is that you can't vaccinate during pregnancy. So patient needed to be having the vaccine before getting pregnant. Okay. Yes, if both is negative, then you can offer vaccination after the pregnancy. That means once delivery is there, delivery is done, then you will advise the patient to get the vaccine. Everyone, even the vaccinated mother, needs to be tested. Okay, so everyone will needed to be tested. Next, varicella. So varicella or chicken pox also comes in exam a lot. So the greatest risk if the mother gets infected in the first trimester or the last trimester. So the congenital varicella syndrome includes limb abnormality, microcephaly, optic atrophy, mental impairment. So you can see that there is a lot of problem if the baby gets varicella. So how to diagnose this? Same, if there is a contact, you need to arrange the blood test for IgG and IgM. And it's pretty much same. If IgG positive, patient is immune. If IgM positive, patient is infected. Now, it is very important to understand what they have written in here, these 3 lines. First of all, patient is just a contact, which means that patient had a recent contact with someone infected with varicella or chickenpox, but patient is not infected at the moment. Okay? So that's the contact. That means patient had a contact and you tested the patient for IgG and you found that patient's IgM is negative and IgG is also negative. Now, because IgG is negative, the patient still have a risk that the patient can get infected. So that's called seronegative. So if patient is seronegative, means that patient still can develop infection because she is a contact. So for that patient, you need to give them varicella zoster immunoglobulin immediately, ideally within 48 hours of contact. So that's for contact who is not infected yet, because you have found both IgM and IgG negative. Let's say mother is infected. That means IgM positive. If mother is infected, then you need to give them a course of antiviral, oral antiviral, acyclovir, valacyclovir, and then you can consider doing an ultrasound to see if the baby is developing any of this fetal varicella syndrome. If maternal infection happen in the late pregnancy, like maybe at the end of the pregnancy, the greatest risk is 5 days before delivery and up to 4 weeks after delivery. So if the mother gets infected in late pregnancy, then consider giving varicella zoster immunoglobulin for the baby. Okay, so if mother gets infected less than 7 days before delivery, up to 4 weeks after delivery. So 1 week before delivery and 4 weeks after delivery, during this time, if mother get infected, then you need to give the immunoglobulin to the baby. Okay? Making sense for everyone? Rubella serology is routinely done for everyone in first trimester blood test. That's right, Dr. Sneha. And serology is not done every trimester. For rubella, you do it on the first trimester to check their antibody level, but you only do it after exposure. Which one to repeat, Dr. Faisal? Can you specify? Okay, last two ones. So if mother is infected in early pregnancy, then you need to give them antiviral. If mother is infected in the late pregnancy, especially we say if 1 week before delivery up to 4 weeks after delivery. So 1 week before delivery and 4 weeks after delivery. In this time, if mother gets infected, then baby will need the immunoglobulin. Mother doesn't need anything. IgG will be positive for lifelong. Once patient get it, it will be positive for lifelong. But sometimes rubella immunity goes down. So we say that sometimes, like if the patient even got vaccination during their childhood, the immunity against rubella can get low. So that's why even for vaccinated patient, we need to do it. It's very unusual that someone will become both IgM and IgG positive. Okay, Dr. Sana. But there is a condition for CMV where we can get both positive. But for rubella, nothing needed to be done. We'll discuss that later on. And rubella screening is done for every pregnant patient in the first trimester. So we will discuss the pre-pregnancy care just after this chapter. And you will see that for every pregnant patient, in the first trimester blood test, we check the rubella status. But for other patients, it's just after contact. Now, Dr. Mehra, we do both. We just don't do a varicella IgG. Most of the time, we will be doing both IgG and IgM. But yes, we need both. Although in JM they say just do a IgG, but normally we would do both. Because what if IgG is negative, but IgM is positive, right? IgM positive means that patient is already infected. So without ruling out that patient is infected at the moment, you can't just think that she is a contact. Yes, you need to do it. So even if there is a previous history of chickenpox, still you will need to check the serology. No need of antiviral in a pregnant patient if they are in the third trimester. But we have seen questions where there is no options rather than just giving an antiviral. So it's not like we can give it, but it's not like really important like this one. If patient plans to get pregnant, yes, we check rubella antibody status. And it's not in the lecture note, you have to open JM 6th edition. Okay, guys, moving on. Parvovirus B19. So parvovirus B19, if you remember our pediatric class, parvovirus causes slapped cheek syndrome, right, in children. So it's a viral infection. The problem with this that if mother gets contact with a child or with someone who has parvovirus B19, and if mother gets infected, this can transmit to the baby, especially in the third trimester. And if it transmits to the baby in third trimester, it can cause stillbirth or intrauterine fetal death due to severe fetal anemia, because it can cause hydrops fetalis. So that's the problem. So parvovirus B19 although it is just a very simple viral infection, but if pregnant mother get it and it can transmit to the baby in utero, then the baby can die sometimes because of anemia. So if there is a contact history, then you need to check the IgG level. If IgG is positive, then you can reassure the mother that there is nothing wrong, you are immune to it. But if IgM is positive, then you would say that the patient is infected. Miscarriage rate is 4% if contact less than 20 weeks, but if infection occur in the third trimester, it can cause stillbirth. So fetal parvovirus syndrome is anemia hydrops fetalis with cardiac failure and possibly death. So if infection occurs during pregnancy, refer the patient for fetal monitoring by ultrasound. If hydrops, consider early blood transfusion. Okay, so basically if there is a contact, you do a IgG and IgM. If IgM positive, it means it's infected. Then you need to send the patient for an ultrasound and regular fetal monitoring. If there is hydrops fetalis, patient or the child will need early blood transfusion. The question can ask you sometime that what is the most common cause of intrauterine infection? The commonest cause of intrauterine infection is cytomegalovirus. And it is the commonest viral cause of birth defect also. So most of the time, CMV infection is totally asymptomatic. The fetus is most vulnerable in early pregnancy. So again, same thing, you do IgG and IgM. If IgM positive, it's infection. Up to 30% of CMV infected infant will have mental impairment. 50% will have hearing loss. So you can see it is not something really like simple infection. 50% can get hearing loss. So if the mother is infected, in that case, you need to consider referring the patient to the obstetric department and also fetal-maternal medicine. You refer the patient for amniocentesis. So most of the time they start with an ultrasound to rule out any fetal abnormality, and they can also do an amniocentesis to find out that if the baby has also got the infection. So that's CMV and parvovirus B19. Okay, Dr. Mitra, you need to share that question with me so that I can see what was the question and options, and then I can answer this. Okay. Hepatitis B. So hepatitis B infection is not uncommon, and every pregnant patient in their first trimester blood test, we screen them for hepatitis B and C. So everyone will be screened for hepatitis B and C during pregnancy. If HBsAg positive, so if surface antigen is positive, it can suggest acute infection. If HBeAg positive, it means it's highly infected. And if anti-hepatitis B antibody is positive, it means patient has antibody against it. But mainly you need to remember, if you have found a patient who has got surface antigen positive, HBeAg positive, and even anti-core antibody IgM positive, if all of these are positive, then it is acute hepatitis B. So vertical transmission during labor is the main concern because it mainly transmits through the blood, right? So during normal vaginal delivery, sometimes if there is any kind of mix of blood between mother and baby, it can go into the baby. So infected infant have 90% risk of becoming chronic carrier. So that's why if the mother is diagnosed to have a acute hepatitis B, everyone, like every child, will get a hepatitis B vaccine and a hepatitis B immunoglobulin after birth. Okay, so that comes in exam. So mother is a carrier of hepatitis B. Then the child will get hepatitis B vaccine and immunoglobulin immediately after delivery. Okay. How about hepatitis C? Again, we will test every pregnant patient for hepatitis C in the first trimester. If mother is a carrier of hepatitis C virus, then you can't give anything. So there is no vaccine or immunoglobulin against hepatitis C. So you can't do anything actually in this patient, but you need to screen the infant 12 months after the delivery to see that if the infant is also infected. And if infant is infected, then sometimes there are some antiviral that can be given to treat hepatitis C. In JAM, it's written 12 months, but in some other guideline of Australia, they have written 18 months. So both is correct. So whatever comes in the exam, you can go with that. Okay. If both 12 and 18 months is in the option, we would go for 18 months because that's more commonly done. Okay. So if mother is a carrier of hepatitis C virus, then the infant needs to be screened at 12 months or 18 months to see if the infant is also infected. Okay. Next, genital herpes. So both primary genital herpes and recurrent herpes can be a risk to the neonate. The risk from primary infection is greatest if the infection occurs after 28 week of gestation. So after second trimester, if there is infection, then it is risky for the baby. The main problem is vertical transmission during labor. So this is the same thing. So during labor, when the delivery happens, sometimes if mother is infected with herpes, like actively infected, it can be transmitted to the baby. Okay, so if you have found a patient who is complaining of like a burning rash in their vaginal area, then you would think that that is the only cause. Usually the burning kind of rash in the around the vaginal area is genital herpes. So if that is the case, you need to perform a swab. So you take a cervical swab and you send it for HSV, which is herpes simplex virus PCR. And that can confirm if the patient has got infection at the moment or not. Consider prophylactic antiviral for mother from 38 weeks until the delivery to try to prevent recurrent herpes in late pregnancy. So what we normally do that if the patient tested positive for herpes simplex virus, then prophylactically you need to give antiviral from 38 weeks until delivery. Okay, and we normally advise that cesarean section is better if the patient has got an active lesion or active herpetic lesions during delivery time. So during delivery time or even within the last 4 days of delivery, if the patient has active herpetic lesion in the genital area, then better to go for a C-section. Or if there is a premature rupture of membrane, also during that time, better to go for a C-section. Now, even after that, if patient refuse to go for C-section and patient goes for vaginal delivery, then after birth, you need to give oral antiviral like oral acyclovir to the baby. All right. So step-by-step management. So if a patient has got features of herpes, first you do a cervical swab, send it for PCR. If it is infected, prophylactic antiviral from 38 weeks until delivery. C-section if there is active lesion or premature rupture of membrane. If vaginal delivery, then the neonate will get the antiviral. Okay. HIV. The fetal infection from a HIV positive mother is about 15 to 25%. So we say that again, for every pregnant patient, they will get a test to check their HIV status in the first trimester blood test. If that is screening detect that mother is HIV positive, then ideally both mother and the newborn will require a antiretroviral treatment. Because HIV also transmits through blood or sex, but mainly for baby it is likely chance blood transfusion. So C-section is usually indicated for this patient because there is a risk of vertical transmission if the patient goes for the vaginal delivery. So how we can reduce the risk of transmission from mother to the baby? One, by elective C-section. Second, by avoiding breastfeeding, and by treatment with antiretroviral, which is gidovudin, prescribed for the mother and also the neonate. Okay, so that's how we normally treat the HIV positive mother. Listeriosis. Should we give antiviral to all babies even without active lesion? Yes. So if we normally say that if vaginal delivery, so the mother is actually positive for herpes simplex virus. Okay. When it is positive, likely chance that baby will get it either through blood, or if there is no active lesion, then it can transmit through the blood. If there is active lesion, then definitely just even with contact. So even if there is no active lesion, if it goes for vaginal delivery, yes, the neonate will need acyclovir. When do we start antiviral for mother? Most of the time, it usually happens after the first trimester. Do we need to check viral load? No, we don't need to do it because this will be done by infectious disease specialists. They will do all of these things. This doesn't make sense. That's right, Dr. Sophia. So membrane rupture less than 4 hours. That's right. Usually, yes, it is. It should be actually 4 hours. 4 hours ago. I think they are just trying to say if membrane ruptured 4 hours before delivery or something like that. Not very important for this one. It's mainly for active lesion. Listeriosis. So listeriosis is an infection by gram-positive bacteria, and if mother gets infected, baby can get infected, and there is a high risk of fetal mortality with that. So it usually comes with infected food, like if mother gets soft cheese, then unpasteurized milk, raw meat, raw seafood, or raw meat. Okay, so that's why we advise pregnant patient not to have soft cheese or unpasteurized milk because it can transmit listeria. The symptoms will be kind of a vague symptom: fever, headache, myalgia, vomiting, diarrhea. So it's very difficult to find out. But when there will be high fever in this patient, and you will do a blood culture, and blood culture will get it positive. Once it is positive, then the treatment is very simple, just amoxicillin. Usually you do it after first trimester. Okay. All right, guys. So that's all about infections during pregnancy. Any questions? Okay, we'll take a 10-minute break now. And after that, we still have got a lot of things to finish. So let's All right, everyone, let's continue. So the answer to this question, Dr. Chandima, would be, although I don't think this is an exam question, but if this is a gestational hypertension, we would refer the patient to an obstetrician. Okay, so you'll need to write a letter to an obstetrician in the hospital. They will have a look. We don't need to send the patient to hospital straight away, but given it is mild hypertension, patient can wait and see the obstetrician. Okay, moving on to the labor. So stages of labor is important for some of the questions that comes in exam. So we'll show you some of the important things, the normal and abnormal. And there's the idea that everyone needs to go for cesarean section. That idea also is not a good thing for AMC. So you'll need to know that in Australia, especially for AMC, rarely you would ever go for a C-section unless it is really needed. Okay, let me just find that video. 1 second. So now we're going to show you the stages of labor. So there are 3 stages, first, second, and third. First of all, to know what is abnormal labor, you need to know the normal labor. So once we know the normal, then we can easily identify what's abnormal. Okay. And again, for AMC, you don't need to be an obstetrician. All you need to have is a basic idea, because they don't usually like test you for too much obstetrics.
Labor, also called parturition, describes the hard work of delivering a baby. It specifically refers to the process which starts with uterine contractions which cause cervical changes, which allow the fetus to be delivered vaginally, and ends with the delivery of the placenta. Labor typically begins at some point when the fetus is considered full term, between 37 and 42 weeks gestation. In the 3rd trimester, before labor starts, a woman might have a plug of mucus and blood fall out of the opening to the cervix, sometimes called the bloody show. Other times, the amniotic sac might rupture, sometimes called water breaking. Either of these can trigger the onset of labor and so-called true labor contractions. These guys have to be distinguished from the milder and ineffective false labor contractions, also called Braxton-Hicks contractions, or sometimes called practice contractions. Once they start, true labor contractions progress in frequency, duration, and intensity, and they can feel like waves that build up to a peak intensity and then gradually decrease. The contractions pull on the thick tissues of the cervix, causing it to efface or get thinner, and also dilate or open up. So then, the fetus can leave the uterus and enter the world. From the moment true contractions begin to the baby's delivery usually takes about 12 to 18 hours for a first-time pregnancy, and about half that time for subsequent pregnancies. Although, as any mother knows, this time can vary a lot. Even though labor is a continuous process, it can be broken down into 3 stages. Additionally, this first stage is subdivided into 2 phases. The first phase is the early phase or latent phase, and usually lasts up to 20 hours, or until the cervix dilates to 6 centimeters. At first, there are irregular contractions that occur every 5 to 30 minutes and last about 30 seconds each, causing the cervix to dilate from 0 centimeters to about 3 centimeters, and efface from about 0% to 30%. Then, regular contractions follow. They happen every 3 to 5 minutes and last about a minute or more. And this causes the cervix to dilate from 3 centimeters to about 6 centimeters and efface up to about 80%.
So you can understand from here that how the cervical dilation is happening, and also effacement is, see the thickness of the cervix here and see it here. So the The effacement is means like thinning of the cervix. Okay, so up to 6 centimeters cervical dilation is what we call as latent phase of first stage of labor.
This marks the beginning of the active phase of labor, during which the cervix dilates from 6 to 10 centimeters and effaces to 100%. Contractions are very intense, lasting between 60 to 90 seconds each, with only 30 seconds to 2 minutes of rest in between, so sometimes they can even overlap a bit, with one contraction beginning before the previous one is done. Also, the amniotic sac often ruptures at this point if it hasn't already. Now that the cervix is fully dilated, we enter the second stage of labor, and this can be thought of as the pushing stage. During this stage, the critical thing is for the baby, and in particular the baby's head, to navigate through the maternal pelvis, and this depends on the 3 P's: power, passenger, and passage. Power refers to the forceful uterine contractions. Passenger refers to the fetus, and passage refers to the route that the fetus has to travel through the bony pelvis. In fact, the relationship between the baby's head and the bony pelvis is so critical that human babies have evolved with unfused skulls, just so their head can be as large as possible and still successfully and safely make that passage through the pelvis into the world. Now, there are a few factors that determine how easy this passage is for the fetus. First is fetal size. The critical factor here is the size of the fetal head. Also, there's fetal attitude, which refers to the way that the fetal body is flexed, not its personality. When labor starts, the fetus is normally fully flexed, which means the chin is on the chest, and they have a rounded back with flexed arms and legs. In this position, the smallest diameter, which is referred to as a suboccipitobregmatic diameter, presents at the pelvic inlet. Larger fetuses, and those that aren't completely flexed, have more difficulty making it through the passage. Next, there's fetal lie, which describes how the fetus is positioned in the uterus. A longitudinal fetal lie is ideal, where the long axis of the fetus, which is its spine, lies along the maternal long axis, the mom's spine. The fetus can also be transverse, though, where the fetal spine is perpendicular to mom's spine, or it can be oblique, where it's slightly at an angle, and these two positions can impede the progression of labor. Finally, there's fetal presentation, which refers to the first fetal part, called the presenting part, to descend into the pelvic inlet. Cephalic, or head first, is the first type, and furthermore, the most common and optimal presentation for easy delivery is a type of cephalic presentation called vertex, which includes complete flexion of the head as well. Also, there's breech presentation, which is head up, so the bottom, feet, or knees present first, as well as shoulder, where the shoulders present first. To make it through the passage, the fetus makes several positional changes, which are called cardinal movements or mechanisms of labor. Initially, there's descent, which is a downward movement of the fetus into the pelvic inlet. The degree of descent is called the fetal station, which is described in terms of...
Okay, so the fetal station is a very important thing. It comes in exam. They don't ask that what is the station of the fetus, but they always give you a clue that if the fetus is engaged or not. Okay, so listen to this carefully.
The relationship of the presenting part to mom's ischial spines. The fetus moves from the pelvic inlet, which is at about -5 station, down to the ischial spines, which is station 0, and this position is called engagement. Then there's flexion, where the fetal chin presses against its chest as its head meets resistance from the pelvic floor. Next, there's internal rotation, where the fetal shoulders internally rotate by 45 degrees so that the widest part of the shoulders are in line with the widest part of the pelvic inlet. After the fetal head passes under the symphysis pubis, which is at about +4 station, there's extension, which is where the fetal head will change from flexion to extension, and then they move to about +5 station and emerge from the vagina. After the delivery of the head, there's restitution, where the head externally rotates, and finally, there's expulsion, the third stage of labor occurs after the baby has been delivered, and involves delivery of the placenta. After the baby is delivered, the uterus contracts firmly, and the placenta begins to separate from the uterine wall. It's then carefully removed to ensure that there are no placental remnants left in the uterus. Sometimes, several hours after delivery.
Okay, so that's basically all that you really need to know about the normal stages of labor. Okay, so let's recapitulate what you have learned from the video. So we have learned that there are several changes that happened in the cervix for the baby to descend properly, right? So cervical dilation and effacement. So normal labor is characterized by transition from latent to active labor, progress in active phase of labor. Now this time is important. It is important for you to know this normal duration to get the abnormal duration. So we say that active phase of labor, it should progress about like 1.2 centimeter per hour for nulliparous, 1.5 for multiparous. So you can remember at least 1 centimeter per hour. So it basically means that, let's say 6 centimeter cervical dilation, then the active stage started. Then every hour it should have, like next hour it should be 7 centimeter, then next hour 8 centimeters. So at least every hour 1 centimeter dilation should happen. The second stage of labor should be less than 3 hours for nulliparous and less than 1 hour for multiparous. So stage 1. So stage 1 starts with uterine contraction and ends with complete cervical dilation at 10 centimeter. Okay, so there is latent phase. So in the latent phase, basically the patient will have cervical dilation up to 6 centimeter. Okay, the upper limit of latent phase, maybe it can be even 20 hours in a primipara and 14 hours in multipara. So latent phase is, it's just like it just starts with contraction, and then there is gradually the cervix becomes dilated and effaced. And usually there is nothing wrong with a bit of prolonged latent phase. Okay, so 20 hours you can wait for this latent phase to become active phase for a primigravida patient. That means first time mother. Active phase starts with cervical dilation at 6 centimeters. So from 6 centimeter dilation, the active stage of labor will start and then ends when cervical dilation is 10 centimeter. So the average rate of dilation should be, now in here they say that ideally it should be at least 2 centimeter per hour. In multiparous, average rate of cervical dilation should be at least 3 centimeter per hour. So that's optimal, but it's not like they say that abnormal would be less than 0.7 or less than 1. So we normally keep it like this. If the patient is in active stage of labor and dilation is less than 1 centimeter per hour, then we would think that it is abnormal. Okay? That's one thing that you should remember. Stage 2 begins with complete cervical dilation, which is 10 centimeter, and ends with delivery of the baby. So stage 2, as you have seen from the video, it requires appropriate fetal size, the contraction, and also a normal pelvic size as well. The stage 2 duration can be up to 3 hours in primi and 2 hours in multi. Stage 3 is basically after delivery of the fetus. Stage 3 means delivery of the placenta. For both primi and multipara, the duration of stage 3 is 30 minutes. So this is a very good table where they have explained everything that we have just discussed. Okay, now that you know about the normal labor, now we move on to abnormal labor. So first of all, prolonged latent phase. So prolonged latent phase is patient having regular contraction, but cervical dilation is still less than 6 centimeter. That means patient is still in latent phase after 20 hour in priming and after 14 hour in multi. Okay. So if latent phase is more than 20 hour in priming or more than 14 in multipara, that's prolonged latent phase. So there are a few causes of prolonged latent phase. One, that sometimes you might be giving a lot of analgesia and patient getting more sedated, so the contraction is not happening properly. So that can be one thing. Other thing is that maybe there is something wrong with the contraction. So if contraction is hypotonic, that means patient is not getting, like, the duration or intensity of the uterine contraction is not normal or it's low. So hypotonic contraction, or it could be like patient getting like highly intense contraction. So more contraction, but not enough contraction. So you can say, like, when it's contracting heavily, but it's not happening frequently. So basically, either contraction is low or contraction is very high. So if it is hypotonic contraction, then you can increase the contraction by giving oxytocin or syntocinon. So in Australia, we don't call it oxytocin, we call it syntocinon. Okay. If patient having hypertonic, that means if the contraction are really intense, the best idea would be to just, if the membrane has not ruptured yet, then you can just do a rupture of the membrane, and that will also increase the, like, it will also increase the chance that from latent phase it can go into active phase. Okay. What if you are not giving enough painkiller? If you haven't given enough painkiller and that's why it's not progressing, then definitely you can give them some more painkiller. If you have given more, then you will reduce it. Remember, cesarean section is never an appropriate management for a prolonged latent phase. So most of the time, this kind of like maneuver that you are doing, it will lead the latent phase into active phase. So you never go for a cesarean section. Okay, almost unusual. So you would not think of cesarean section just because it is a prolonged latent phase. So there must be something which is causing it. Now, more important is arrested active phase of labor. So let's say patient is in the active phase of labor. So cervix is now dilated more than 6 centimeter. Membrane has been ruptured, but cervical dilation hasn't changed for more than 4 hours with adequate contraction, or more than 6 hours with inadequate contraction. Okay. Basically, we say that if there is no change of the cervical dilation for 4 hours in a patient who has got good contraction, that's arrested active phase of labor. So first thing that you need to do is to find out how is the uterine contractions quality. So ideally in active phase, contraction should happen every 2 to 3 minutes, lasting 45 to 60 seconds with 50 millimeter mercury intensity. So that's the normal thing. If contractions are hypotonic, that means less than 50 millimeter, then you will give oxytocin to increase the contraction. If contractions are hypertonic, then you can reduce the contraction by giving some sedatives like morphine or pethidine. What if contraction is adequate? Now that's the time you would say it is an arrested active phase of labor. So in that case, you can think of going for an emergency C-section. Okay, so remember, arrested active phase of labor means when a patient has got a regular uterine contraction, that means contraction is normal, but still the active phase is just not moving at all for the next 4 hours. That's arrested active phase. Okay, makes sense for everyone? Next, prolonged second stage. Prolonged second stage means after complete cervical dilation, there is no progress or no descent of the baby after 3 hours. So in a nulliparous patient, after they have a complete cervical dilation, if there is no descent of the baby in 3 hours. For multiparous, if there is no progress after 2 hours. That's prolonged second stage. Again, before you say prolonged second stage, you need to assess how is the contraction and how is the maternal pushing. Okay, if contraction is not good, you can give oxytocin. And you need to also encourage the mother to push harder. If maternal push and the contraction both adequate, first find out what is the station of the baby. That means if the baby's head is engaged. When we will say baby's head is engaged? If the question says station 0. If the head is not engaged, proceed to emergency cesarean section. If head is engaged, then you can try a assisted delivery with either forceps or vacuum. Okay, so that's prolonged second stage of labor. So prolonged second stage, you can think that after patient had a complete dilation of the cervix, for nulliparous patient, no descent after 3 hours. For multiparous, no descent after 2 hours. So for that patient, first find out contraction and maternal pushing. If both adequate, find out how is the head. If it is engaged, then you can do forceps or vacuum. If head is not engaged, then emergency C-section. Here for the hypertonic contractions, can't we do an amniotomy? Ideally, when patient is in active phase of labor, they would already have a ruptured membrane. So you can see that arrested active phase, first thing is membrane are ruptured. The membrane will be ruptured. And there is no specific duration of active phase, Dr. Sana. It mainly is the progression is the important thing for active phase. Okay, so for active phase, it's the progression. So the cervical dilation should progress at least 1 centimeter per hour. So that's basically your main part that you need to remember. So the questions can come from maybe a prolonged second stage or from arrested first stage of labor. So these two is usually the commonly asked thing. Okay, but main thing is always about contractions. So you need to make sure contraction is good. We'll practice few of the questions that comes from labor later on. Any questions with this? So these are obstructed labor. So if the baby is not descending, that's obstructed labor or prolonged labor. So obstructed, most of the time we say that, let's say that there is shoulder presentation and the baby is not progressing or descending at all. So when the baby is not descending at all, that means it is an obstructed labor. Okay, so very important thing to know that how we normally take care of a pregnant patient. So in Australia, every pregnant patient goes through frequent antenatal care and visits. The first time a pregnant patient comes to you, so they might come to you to say that their home pregnancy test is positive. or or they missed their period. So first thing you do is you do a urine pregnancy test, even if they have done a home pregnancy. If the urine pregnancy test is positive at your clinic, then you can confirm that yes, you are pregnant. You don't need in the blood to confirm pregnancy, but still we normally do it anyway. So once you confirm that patient is pregnant, in the first trimester visit, that means the first time you find it out, you will order several investigations, and those are called first trimester screening test. So the first trimester screening test includes some blood test and some urine test. So blood test will include, so everyone will get full blood count, iron status, blood group Rh typing, rubella antibody status, pap smear, if not, we don't say pap smear, cervical screening if it's due for more than 12 months. We also do a full STI screening, which is Hep B, Hep C, HIV, and syphilis. And then also a routine urine microscopy and culture. So that will be for everyone. For some patient, if they are like someone who doesn't get that much of a sun, or Asian like immigrant, they have risk of getting vitamin D deficiency. For them, we will check it. Varicella serology for someone who works in childcare, increased risk of getting that, so you can check that as well. Hemoglobin electrophoresis is not indicated. Okay, so that will be your first trimester blood test. After that, ideally we say that everyone should be talked or should be advised to get a Down syndrome screening. So there are several Down syndrome screening that we will discuss today. So Down syndrome screening, there are few tests that we do in first trimester, and there are few tests that we do in second trimester. So in the first trimester, when we do the Down syndrome screening, we do a blood test and also an ultrasound. So in the blood test, we check for 2 hormones, and we will discuss what those hormones are called. So one is PA-PPA and beta-HCG. So with the hormone, we also do nuchal translucency, which is an ultrasound to detect the neck fold thickness of the baby. So together with the blood test and this nuchal translucency or nuchal ultrasound, it can give us an idea that how much is the risk for this baby to get a Down syndrome. So this is just a screening test, not definitive. If a screening test is positive in first trimester, then you can send the patient for a definitive test, which is what we call as chorionic villus sampling. And these are all done in first trimester, so before 12 weeks. If patient missed the first trimester Down syndrome screening, then in the second trimester, you can do a screening test, which will be some hormone test. So there are 3 hormone tests that we do. If hormone test shows that patient has high risk of Down syndrome, then the definitive test will be amniocentesis. Okay, so that's pretty much a little bit of idea about Down syndrome screening. After this is done, around 18 to 20 weeks, you do a morphology scan, which is an ultrasound to detect the baby's, like all the organs and everything. And during this time, you can also know the sex or gender of the baby. Then, around 26 to 28 weeks, everyone will get an oral glucose tolerance test, OGTT. Nowadays, this oral glucose challenge test is no longer needed. So we don't do it anymore, so we do OGTT. Then at 28 and at 34 weeks, Rh negative mother will get a anti-D immunoglobulin. Okay, at 36 weeks, we again check their full blood count and we do the GBS test. which is the vaginal swab. So that's all the common pregnancy screening test for every pregnant mother in Australia. Okay? And there are some common routine schedules which you don't need to memorize. You can just remember it. That will do. So thalassemia is not important for Australia because rarely we get thalassemic patient here. But if it is a known thalassemia, we don't need to do anything because we already know it is a thalassemia patient. Okay? And there is no specific test that needed because it's a diagnostic, like patient is already a diagnosed case. All right, but if someone is like having anemia and their iron status shows normal, that's the time we can do a hemoglobin electrophoresis to rule out thalassemia. Can be done at any age. And cervical screening test is if a patient is due. It's not needed for anyone who is not due. So nowadays it's 4-5 years. Like if the patient is due for having a cervical screening test, then only you would do it. Otherwise, no need. Yes, so anomaly scan and morphology scan is same. If definitive test is positive, then normally you would need to tell the patient that you have a high risk of a Down syndrome baby. What do you want to do? Do you want to continue or terminate? Yes, definitely. If a screening test, it doesn't say anything. It just say it is a high risk of having a Down syndrome baby. Okay, so yes, karyotyping is absolutely necessary. Guidelines for OGTT. So as you know that for every patient, around 26 to 28 weeks, we are going to do OGTT. But there are few patients who might need the OGTT in their first visit, which is if someone had a previous gestational diabetes or if there is a strong family history of diabetes. For this group of patients, you will do the OGTT in the first visit. And if their initial test was normal, then at 20 weeks, you will again do a OGTT for this group. Next, symphysiofundal height. As the pregnancy progresses, the fundal height will also increase. So by the time patient is 12 weeks pregnant, that's the time the uterus will be palpable. So around 12 weeks, uterus becomes a pelvic organ. Then at 20 weeks, the uterus reach towards the umbilicus. And then at 36 or between 36 to 40 weeks, it comes to Giffey-Sternum. Normally we say if the symphysiofundal height, that means this is pubic symphysis and then fundal height. So symphysiofundal height should be more than, should be plus minus 2 centimeter from the gestational age. So gestational age, let's say, is a 30 weeks pregnant patient. Their symphysiofundal height should be between 30 plus minus 2 centimeter. If it is more than, let's say, so it means 28 to 32 centimeter. If it is less than 28 centimeter or more than 32 centimeter, both is abnormal. In that case, you need to send the patient for an ultrasound. Okay, so if symphysiofundal height is more than 2 centimeter, then the gestational age, you would be thinking about like fundal height larger than the gestational age. And the most important cause will be polyhydramnios. On the contrary, if it is less than 2 centimeter, then you could think of oligohydramnios. So both of the time you need to do an ultrasound to find out the cause. We discussed about vaginal bleeding, miscarriages. What is hyperemesis gravidarum? So hyperemesis gravidarum is severe vomiting during pregnancy. Every pregnant patient in the first trimester, they have morning sickness and some will vomit. That's normal. But if it is excessive, that patient becomes like drowsy, can't keep anything down below, that's not normal. So you need to rule out few things in that case. So molar pregnancy should be ruled out, multiple pregnancy like twin or triplet, and also sometimes can be due to UTI or gastroenteritis. So if you suspect hyperemesis gravidarum, definitely first you do a urine microscopy and culture. So if you see that patient having ketone positive, that means patient is dehydrated. For that patient, you need to send them to hospital for IV fluid. You will also do blood test and ultrasound to rule out this other condition. If everything is good, then patient will need few things. One, that definitely fluid and electrolyte replacement, and you can give them metoclopramide, and if that is not effective, ondansetron. Okay, so ideally, if it is severe enough, dehydration, their urine ketone is positive, patient will go to hospital. If urine ketone is not positive, then you can do everything, like all the tests in your clinic, and then put the patient with like antiemetic and see how the patient goes. But if the patient can't keep anything down below, getting severely dehydrated, needs to send to hospital. No, urine test should be first. Which one is easier, urine or ultrasound? Urine. So definitely urine test should be done first to rule out UTI, find out if the patient has got ketone in the urine, and then ultrasound. Even before ultrasound, blood test. Okay, coming back to Down syndrome screening. So in the first trimester, as I said, we do the maternal serum screening, which means we do a blood test to check these two hormones. And also we do a nuchal translucency test. So ideally, this should be done in the late part of the first trimester. So between 9 to 13 weeks, this time you would be doing both blood test and this ultrasound. Then second trimester, usually we do the hormone test for 3 hormones between 15 to 16 weeks. Nowadays, there is also another test available, which is this free fetal DNA test. So free fetal DNA test can be performed at any gestational age. So you can do it in between 10 to 12 weeks. You can even do second trimester. This will also give you a good diagnosis of any chromosomal or genetic abnormality and also the sex of the baby. But this is also screening. So either you can do any of those other tests or you can do this free fetal DNA test. If this comes positive, or if it comes positive in first trimester, you do CVS, or chorionic villus sampling. If it's positive in second trimester, you do amniocentesis, just like the others. So what are those 3 hormone tests that we are talking about? The 3 hormone tests that we do is maternal serum AFP, HCG, and estriol. Previously, we used to do inhibin A. Nowadays, it's not needed. So these are the 3 hormone tests that's needed. If it is Down syndrome, then you will get decrease of AFP and estriol, and HCG will be elevated. Okay, so in trisomy 21, the AFP and estriol will be reduced, but HCG will be high. And in trisomy 18, which is Edwards syndrome, all 3 hormones will be negative or will be decreased, sorry. Okay. So that's pretty much all about Down syndrome screening and first trimester screening. Any question? Down syndrome screening should be offered to every patient. It's not mandatory. So patient can choose that if they want to do it or not. But it is like very much recommended for patients who are elderly primigravida or elderly pregnant patient above 35. And it is preferred to be done in first trimester, but if they miss it, you can still do it in second trimester. Okay, the next thing is cervical incompetence or cervical insufficiency. So that's a condition which also causes like a recurrent miscarriage, but most of the time it causes recurrent miscarriage in second trimester. So what cervical insufficiency means? It means inability of the cervix to retain a pregnancy. That means if the cervix is weak, then it will not be able to retain the pregnancy. So a diagnosis is made on the basis of a past history of painless cervical dilation after the first trimester with expulsion of a viable living fetus. So if the cervix is weak enough that it can't retain the pregnancy and baby just came out, that's cervical insufficiency. The only way to diagnose this is to do an ultrasound. If you do an ultrasound in the second trimester and if it shows that cervix is weak, that will give you the diagnosis. And also if you get that there is frequent second trimester pregnancy loss, you would also consider possibility of a cervical incompetence. For those patients, we put this elective sarclase in the second trimester, and this sarclase is just kind of, you can say, something which will strengthen the cervix. So that's elective sarclase placement. And then by the time the patient reaches term, this sarclase will be removed so that the baby can start to descend when labor pain starts. It's up to them, Dr. Nahid. So you always give them the option. Just because Down syndrome is diagnosed doesn't mean that they need to go for abortion. You give the choice that if you want to continue, that's all right. If you want to go for miscarriage, we can also go for termination. So it's the patient's choice always. Okay, let's do some practice question, guys. Let's see how did you learn. So 38-year-old, gravida 1, para 0, 38 weeks pregnant, coming to the emergency after a spontaneous rupture of membrane. After 3 hours, no active contraction, syntocinon was given. After 4 hours assessment, uterine contraction is good. But with continuous CTG monitoring, CTG is like baby's heart monitoring. We will discuss CTG later on. There is 60 beat per minute heart rate and slow recovery to normal. On examination, left occipital anterior position, CAPU1, MOLD 1, cervix dilated to 9 centimeter. What is your next appropriate management? What would you do? And Dr. Ayman, no, gynae and OBS notes are not in the same file. It's in the different file. You can check OBS. You can just write OBS in the search box. You should be able to find it. Okay, very good. So most of you are right. Stop syntocinon. Why you want to stop syntocinon in this patient? So first of all, find out. So after 3 hours, no active contraction. Now, first of all, we don't know what it is. Like, is it a latent phase or if the patient is in active phase? But cervix dilated to 9 centimeter, right? That means it is in active phase of labor. So that's, at least we know. We say that after 3 hours, no contraction, then you started the patient with syntocinon. And then after 4 hours, contraction has got better. But when you did the CTG monitoring, the fetal heart rate is going too low, fetal bradycardia. Normal fetal heart rate is ideally between 110 to 160. So it is bradycardia, right? And also, it's coming back to normal. So that means it's not a persistent bradycardia. And that actually should give you a ring that when contractions happening, then the fetal heart rate going too low. Maybe you have given syntocinon more than what is required. Okay, so for that reason, we are stopping syntocinon. And if we stop syntocinon and see that fetal heart rate is getting better, then it's good. The cervix is already dilated to 9 centimeters, so we don't need to go for any more syntocinon. And they also said contraction is good now, so you can definitely stop it. A primigravida patient in spontaneous labor, membrane ruptured 1 hour ago, head 2 centimeters above the spine. That means estimation is -2, vagina 4 centimeters dilated and fully effaced. That means it is still not in active phase. 4 hours later, head is now 1 centimeter above the spine, which means station is now -1, and it's 5 centimeter dilated. What is the next best management? Do another vaginal exam in 4 hours, start oxytocin, start lumbar epidural, or go for CS. Why we want to give oxytocin? Do we know anything about the contraction in this patient? So that's the thing. Don't just think that everyone needs oxytocin. This patient is in latent phase. And just because the dilation has not progressed a lot in 4 hours doesn't mean anything, because you can wait 20 hours for latent phase to become active phase for a primary patient, right? So there is no hurry in this patient that you need to start oxytocin. So you just need to monitor the patient. Everything looks fine in here. They haven't said anything about contraction, so no need to give oxytocin. So you just do another exam in 4 hours. Okay? So very important these things are. Last of all, I will just finish with cervical scoring. Yes, that's fine. So rupture of membrane is nothing to do with like active phase or any other thing. So all we need to see is what phase the patient is in. Is the patient is in latent phase or active phase? Sometimes we do induction of labor, right? Especially for patient with some medical condition, and sometimes if it is not progressing, so we go for induction of labor. To go for induction of labor, you need to check the cervical score or Bishop's score. So we say that cervix is ripe if Bishop's score is more than 5. Okay. If it is less than 5, you need to ripe the cervix. So how we do that? So you can give them prostaglandin E2, pessary, or gel. After giving prostaglandin E2, you check if the labor has started in 4 to 6 hours. So you check the patient again in 4 to 6 hours. If there is no labor in 4 to 6 hours, you again check the cervical score. Still a score is 0 to 4. You can repeat the no change of the cervical score and no labor in 12 hours, you go for C-section. Okay? But after giving the initial prostaglandin E2, if cervical score is now 5 plus, that means it's now ripened, then you can go for amniotomy and follow the next process. So in here, let's say it is 5 plus. If it is 5 plus, then either you can give prostaglandin E2, but most of the time we do amniotomy. So you can do an artificial rupture of membrane. And then see if in the next 6 hours, if the labor is started or not. If there is no labor in 6 hours, you can do two things. One, that you can give oxytocin, or you can give a prostaglandin pessary. Most of the time, you would go for oxytocin. If no delivery happened in 10 hours, then consider cesarean section. Okay, so you need to know this scoring system. Like you don't need to know how to calculate scoring. You need to know that what has to be done if it is less than 5 and what to do if it is more than 5. Okay. Cervical score and Bishop score is same, and you don't need to know how to calculate. It will be given. Okay, so that's mostly all that we need to discuss. The only thing that you guys just need to go through from John Murtagh, so postnatal care. Postnatal care, not super important. There is not much left in there. So the one thing that is very important to remember that patient after delivery, you need to think of giving them contraceptives. So ideally, the contraceptions we can delay at least 21 days. We say that usually after 6 weeks, you can start the patient with contraception. Okay? So if the patient is breastfeeding, then ideally you would not give them COCP. You can offer them mini pill, which is POP. And once breastfeeding is completed, then they can transition back to COCP. So usually that's the choice of contraception. So ideally 6 weeks is the time. So 6 weeks you can start with mini pill if patient is breastfeeding. Other than that, you can do any other things, IUCD, implant, and everything can be done, and better to wait up to 6 weeks. So you can go through this insufficient milk supply, puerperal fever, that's usually the puerperal sepsis we discussed. So that's pretty much everything. Okay. Two first-degree relative on the same side. It means that same side means either the maternal side or paternal side. Okay? So first-degree relative, let's say your patient's father and also your patient's brother. So both are first degree. They have got colon cancer. So that's first degree relative on the same side. And we talked about this, Dr. Asha, that colorectal cancer, we are following the RACGP guideline, not the new one. That's the new one is just a publication. It's not a guideline yet in Australia. We have been talking about it for every day, I think, nowadays. And Dr. Nahid, this question is not like even, it's not a complete question, doesn't make any sense. I don't know what the question is asking. So I would definitely not like waste any time on this kind of questions. Okay, so you can't even see like what they're actually talking about. Blood pressure is high, CTG normal, 33 weeks, saying UTI. So it doesn't make any sense. So don't even waste any time on this type of question. Okay. And Dr. Sana, I think you were in our class when we discussed this. So I know about like it can be a quite confusing for a lot of people. Okay, so if I said it this very clearly, even if any of our mentors saying that follow the new guideline, I have been working in Australia for a long time to know what is the guideline that we are following. So I've told you that because these are controversial, everyone is confused. It's not our mentors' fault that if they're saying that, because it is the guideline, they have seen that in the new publication, but still we are not following that new publication in Australia. So please don't ask it anymore. Okay, Dr. Sana? I think I answered you also a few times. No more confusion on this. Okay, I'll show one thing. Reduced fetal movement. It's a good question, Dr. Arpita. So there is the RSCGP guideline about reduced fetal movement. So how do you normally like what to do if a patient coming to you that they can't feel the baby's kick? So normal fetal movement. So normal fetal movement is 10 or more fetal movement in 2 hours. So that's normal. So if less than 10 in 2 hours, that means reduced fetal movement. And there is always something concerning. So that is actually what you need to follow. So if a patient coming to you for the first time with a reduced fetal movement after second trimester, you will definitely take a detailed clinical history with the risk factor and everything. If history confirm that yes, this is definitely a reduced fetal movement, then first thing is you need to check if the baby is alive. So you need to do a fetal heart rate. So either you can do a Doppler ultrasound, okay, or even you can do a stethoscope, but you need to check for fetal heart rate for viability. If fetal heart rate is detected, then you do a CTG. If CTG normal, you can reassure no further investigation is needed. Even normal CTG, but patient is still feeling that yes, there is reduced fetal movement. In that case, you do an ultrasound, which is an obstetric ultrasound. If CTG showing no, it's not normal, so either it's non-assuring or abnormal, again, you will need to go for ultrasound. Okay? If you can't get fetal heart rate, there is a chance there is fetal death has happened, then again you need to do an immediate ultrasound to confirm or exclude that. So basically, CTG, obstetric ultrasound. Let's say step-by-step investigation, right? Now, if we go into that question, so a pregnant lady, 37 weeks gestation, comes with the complaint of reduced fetal movement for the last 24 hours. Okay, you have done a CTG, it was normal. Patient was then sent home with reassurance. She now comes again after 3 days that she is not feeling any baby movement. So initially reduced and now more concerned that there is no baby movement. What is the most appropriate next step? Because this is even persisting, even after CTG is normal, we would go for obstetric ultrasound. Okay. Now, if there is an option of doing, like, let's say if you want to do because there is no fetal heart rate, if there was an option of taking the fetal heart rate by Doppler, that would be the first thing. Okay. And Dr. Asha, if anyone having exam in July, we already have everything. So if you go to the previous video lecture option, the previous classes that I have taken, it's already there. So all the classes that has been taken in the previous batch, especially the theory classes, are already given. So you can go through those things from our previous video lecture option. Definitely, if your exam is in July or August, you should finish all those things by yourself. You should not wait for me to finish. Okay. If it was reduced rather than not felt, what to do, please? CTG. We say that if you have done a CTG today and it was reassuring, ideally the CTG should be normal for that means it usually gives us an idea that how would be the baby in the next 7 days also. So if CTG is normal, then we don't need to repeat it. Okay. Ideally, you can go for obstetric ultrasound if the patient having persistent decreased fetal movement, even if that is the case, according to that. Same like 3 days ago, you have done a CTG, it was normal. So in this case, if it is still a persistent reduced movement, you would go for an ultrasound. All right, everyone. So we'll finish it here tonight. And yes, we will, Dr. Sana, we will let them know about it. But you already know that I have told that, so you should not get confused. Okay. So if I say something in the class and you are doing the class, you know what I told. So you don't need to even get confused about it. But that's right, we can always tell them, like, not to tell you about the new guideline. Okay. Thanks everyone. Have a good night.